Good evening and welcome everyone where you are. I'm happy to see you all once again. Last week, this time, we had the annual of our first year of academics. The last week's function was an excellent one, remarkable one, memorable one. We had some opinion from the transatlantic groups, as well as from the Asian group of anesthesiologists and their societies. Mainly we are discussing what will be the future of anesthesiologists and how the career is going to shape. Anyway, the opinion given by people from states, UK, Canada, and say from around India and India were really remarkable. And we have hope to think further about us and our specialty. And again, like that, we may be doing similar sort of opinion making and future decisions from the Far East as well as the Western Europe, say in another 6 months' time. With that, we hope we will be able to draw certain lines and decide how we should go further. And the most memorable event last week was the webinar. The webinar, we had nearly 64 members participating in the webinar, and we had 3 sessions. One to make a preliminary selection, next to groom them, and the final, we had it on 14th. And 5 teams participated, and team 1 and team 2, who came first and second, are given fabulous prizes. Prizes in the nature, memento, well, permission to attend the conference or the ICA annual going to be in December, and TA for some of them, and a book of our publications, and membership for lifetime with ICA. Well, all these things goes to the first and second, and others are also getting some sort of complimentary prizes. And I request Sanish to show the figures and the names of the particular persons who were winning last time. Could you do, Sanish, that?
The first prize goes to Pondicherry Institute of Medical Sciences, Puducherry, Dr. Pratap G and Dr. Sujil Sudarshan. Congratulations. Here is the E certificate. Kindly accept it. The certificate of merit of first place in the ICA PG quiz 2021. That was the first ever online PG quiz, we believe. Certificate for Dr. Sujil Sudarshan. Now, the first runner-up. First runner-up, Dr. Deepa and Dr. Kala Nivedita of Kovai Medical Center and Hospital, Coimbatore. Congratulations. Here is the certificate of merit for Dr. Deepa and Dr. Kala Nivedita.
Thank you, Sanish. Once again, congratulations to our junior colleagues from the Pondicherry Institute, as well as from the Kovai Institute. Well, look forward to see you again and again, and wish you really bright future ahead. And from this year, in fact, this is our first webinar of our second year of academics. And this is going to be an international webinar. And as we promised to you all, when we are changing the format of our webinars from today onwards, we'll be having the conventional webinar, probably we'll be having a debate, and a PG discussion forum as well as case discussions and certain quiz occasionally, and something which is not seen all the times in the Indian scenario are going to come in between. And today, as I said earlier, it's going to be an international webinar. It's going to be on the changing scenario in obstetric anesthetic practice. And the moderator and the coordinator of this program is Dr. Sunanda Gupta, and I am absolutely sure that you are all knowing Dr. Sunanda. Sunanda is an excellent human being, really looking forward to help others. She's a social entrepreneur rather than she's an academically talented, a bright obstetric anesthesiologist. And she was a founder president of Indian Obstetric Anesthesia Society, which with her will and dedication, she was able to get it established, which is now a real force in anesthetic circles to give opinion. And today, Sunanda has picked up some international colleagues from UK as well as from states. Well, Dr. Kodali, you may be knowing, Purva, you may be knowing, Kajal, you may be knowing. Well, most of these particular people here will be individually, they will be introduced by Sunanda. Sunanda, thank you very much for joining us and coordinating this particular program and rolling it for us today. Thank you, Sunanda, and over to you, Sunanda.
Thank you so much, Dr. Radhakrishnan, and welcome all the delegates to the changing scenarios in obstetric anesthesia. And our first speaker today is Dr. Bhavani Kodali. He is presently at the University of Maryland in Baltimore, and he's the Chief of Obstetric Anesthesia Division and also the Chief of Safety Officer. And before joining Baltimore, he was in Harvard Medical School, and his academic inclinations can be witnessed in his review of 16 journals. Sir, how you do it, I'm really wondering the steps. And he was vice chair, clinical chair, and chairman, interim chairman at Harvard Medical School. His main areas of interest are obstetric anesthesiology and respiratory physiology, coagulation, airway, and capnography. And he has also two websites on pain-free birthing and capnography. And world over, that is why he has been named as the Capnoman. With innumerable books, chapters, articles, and multimedia, 264 times. Few, that's a Guinness record, I believe. So we will start with postpartum hemorrhage, which is one of the leading causes of maternal death in our country as well as the world over. And it is alarming. What is alarming is that it's not only in the developing countries, but also in resource-rich countries that obstetric hemorrhage is something we need to look into. And improvements in PPH management have been possible with the latest viscoelastic assays. But as you all know, not many of our centers have this. So there are still many issues which are of prime importance and need addressing urgently. So we have Dr. Bhavani Kodali from Baltimore, who will give us an insight into these alarming issues. Over to you, Dr. Bhavani.
This is a great pleasure to be a part of this ICA meeting. It's about 2 years ago, I was at Delhi for a similar meeting, and hopefully I will have an opportunity to meet all of you. Today, I'm actually going to talk about postpartum hemorrhage. What is the roadmap for optimizing maternal outcome? Now, remember that postpartum hemorrhage is not all that blue and simple. It is really red. And because the uterine blood flow increases during pregnancy from 100 to 700 ml per minute. So within a matter of 3 minutes, you could lose more than 2 liters of blood. Taj Mahal, as you know, is a grim reminder of postpartum hemorrhage, and it has been continuing for last 400 years. And still we are battling how to tackle this critical complication of pregnancy. And you also know that Smita Patil, one of the leading actresses, was also a victim of postpartum complication. Now, when you look at the physiology of pregnancy, it is actually, in a sense, a safeguard to postpartum hemorrhage. Particularly when you look at the cardiovascular effects, where the cardiac output and the blood volume increase. The cardiac output increases from 5 liters to 7.5 liters, and sometimes it can go up to 10 liters. And this is actually a safeguard to postpartum hemorrhage, that they can lose substantial amount of blood before they show signs of crisis. If cardiac output is 6 liters in a morbidly obese pregnant woman, this is not normal. It is definitely low. Same thing with the blood volume. The blood volume increases by about 40%. There is a hypercoagulation, as you all know, in the pregnancy, and this itself is a safeguard for postpartum hemorrhage because of enhanced clotting mechanism in pregnancy. Now, when a postpartum hemorrhage occurs, the life of the woman is hanging by threads. And the presentation can be dramatic. To give you an example, this is a G1P0. Epidural was placed at 2:30 in the afternoon. And I believe the patient coughed at 15 hours and there was a transient decrease in oxygen saturation. And I took over the case around 15:15. And I did comment, I hope it is not amniotic fluid embolism. At 16 hours, I was called into the room for postpartum hemorrhage. And therefore, we took the patient to the operating room for vaginal bleeding. The first coags, as you can see, the INR was 6.1 and PTT is 103 and fibrinogen was less than 60. So we managed the patient with 1:1:1 RBC, plasma, and platelets. We gave cryoprecipitate, we gave calcium, we maintained acid-base balance, and we maintained the temperature of the patient. And we also used synthetic fibrinogen or reconstituted fibrinogen, which is Riostat. The coags did improve after giving all these blood products. And as you can see, at about 8:10, the INR was 1.2, but the patient continued to bleed. And I told them that this is not a coagulopathic bleeding, but seems like most surgical bleeding. After some sort of a debate, they did go for hysterectomy, and the patient stabilized very well after getting about 23 units of blood, plasma, and 21 units of plasma and blood. So overall about 50 units, and the coags normalized by next day very well. So while postpartum hemorrhage occurs and when it occurs, we actually do not know the reason. If we knew the reason, we could have easily prevented it. But the golden rule you have to remember of postpartum hemorrhage is it is unpredictable. So what do you do when you have an unpredictable situation? Well, apart from praying the God, you have to decide which route we want to take. If you don't manage these patients, the failure can lead to death. So therefore, you have to manage these patients successfully in order to pull this a pregnant woman from this postpartum crisis. So when you look at the roadmap, what are the factors you should consider? First of all, you read and understand the current recommendations. There is a lot of literature in every society, in almost all journals concerning pregnancy. There is what is called as a maternal safety bundle for obstetric hemorrhage. So this bundle generally consists of 4 important points. One is readiness. That means the institution or the hospital should be ready to receive and manage an unpredictable postpartum hemorrhage. The second thing is they should have the capacity to recognize and prevent the critical complications of postpartum hemorrhage. Then there is a good plan for response must be already established so that every team member knows what is their role in the critical management of postpartum patient. And the last one, which is more important, is also reporting and systems learning. That means you have a feedback about the management of these patients, what we call as the debrief. Not only the debriefing, the clinicians who took part or the clinical care providers who took part, you also take family into account. So once you have a good understanding about the obstetric bundle or the postpartum or the hemorrhage bundle, you have to prepare and lay out a plan in your institution. The planning must be a multidisciplinary. The obstetricians, anesthesiologists, the ancillary staff, the laboratory personnel, the blood bank personnel, and more importantly, the nurses who actually are taking care of the patients, who sometimes may have a better understanding about what exactly is happening in this patient. So these multidisciplinary meetings should occur and a plan should be laid out. The third important thing is the blood bank. Now, when there is hemorrhage, the blood pours out of the patient. And therefore, what is important is what we call this as a massive blood loss. A massive blood loss needs massive transfusion. What is massive transfusion? Massive transfusion is defined in several ways. Say 50 units of RBCs in 48 hours, 20 units of RBCs in 24 hours, and or at least you can say that 50% of the blood volume is replaced in 3 hours. Probably number 3 is more likely is a scenario in postpartum hemorrhage. So, since a massive blood loss requires massive transfusion, and the massive transfusion requires massive transfusion protocols. Now, if you have a bleeding patient and you keep telling the personnel, yes, it is bleeding, and the anesthesiologist calls the blood bank, and the blood bank calls, the blood banks ask some questions, then the blood comes. So this is a long drawn process. What actually the MTP protocols do is they help to streamline this process. Rapid and timely delivery of large amount of blood products is possible if you have a massive transfusion protocol. There is a predetermined mix of RBCs, FFPs, and platelets that can be sent to the operating room. They reduce the time, the personnel, and the effort required to obtain blood products. So that is the reason why a massive transfusion protocol is necessary. This is a sample of massive transfusion protocol. As I said, in your own institution, you can develop your own massive transfusion protocol, either for postpartum hemorrhage or for any patient with trauma. And usually for a female, you get O negative RBCs, about 6 units, and this is followed by plasma, about 2 units plus another 4 units. And you also get a bag of apheresis platelet. And this is followed by a coolers containing 6 RBCs, 6 plasmas, and 1 platelet as needed for further management. So every institution must have some sort of a massive transfusion protocol. So everyone knows what number to call. Where is tranexamic acid available? Who stores tranexamic acid? Is it freely available in the operating room? So all these factors must be considered before really a postpartum hemorrhage occurs. Now, even in India, there is a lot of emphasis on the availability of blood products to institutions, because it is being documented, as I said, that postpartum hemorrhage is unanticipated. Either intrapartum or postpartum hemorrhage in a pregnant patient is unanticipated. And it is also recognized that access to safe blood can reduce maternal deaths. And it is also known that 30% of maternal deaths are because of postpartum hemorrhage in India. So because of that, it is very important that if you are caring for a pregnant patient, you must have some plan in hand in the management of a postpartum or intrapartum hemorrhage. There is always, when I give this talk in India at, some of the smaller towns or smaller cities, I always advise them on pooling resources from various places. A town may have about 5 or 6 hospitals. And if there is a postpartum or intrapartum hemorrhage, every hospital must help out the other hospital in order to save this patient. The reason being that next time they will be in the recipient situation. And once the blood is pooled and given to the patient, arrangements can be made to return the blood units after getting from donors to the respective places. So there has to be some sort of a pooling of various resources in a given city or town. The next important is backup personnel. Now, it is important that if pregnant patients are being taken care of in any hospital, every clinician must know what are their backups. The nursing team should know who is their backup. Is there a nursing coordinator or a resource nurse? The obstetrician should know who is their backup to do all these procedures necessary to manage an intrapartum or postpartum hemorrhage. For example, a Bactri balloon or a Beeling sutures or uterine artery ligation or even a cesarean hysterectomy. So they must have the backup to do these procedures that needs some expertise. And of course, anesthesiologist also will need a backup because he or she has to perform a massive transfusion protocol. The next important is assessment and estimation of blood loss. Now, we all know that hemorrhage is divided into, various classes: class 1 hemorrhage, class 2 hemorrhage, class 3 hemorrhage, class 4 hemorrhage, depending upon the amount of the blood that is lost. Usually, the patients manifest with tachycardia and hypotension when the blood volume decreases by about 30 to 35%. So when I see a patient with tachycardia or hypotension in a pregnant patient who has got hemorrhage, I pretty much know that the patient could have lost at least 1/3 of the blood volume, and I make preparations for the transfusion protocols. Of course, the class 4 is 40%, which is over 3 liters of blood loss when there's hypotension and oliguria. The second important thing in the estimation of blood loss is, how do you estimate blood loss? The first and the foremost thing which we can always do is a visual estimation. A visual estimation gives us a reasonable number of estimating blood loss. Could be 1.5 liters, 2 liters. Yes, there is error, but at least we know that there is a blood loss. The second method is a quantitative estimation by weight. So if you are going to take care of the pregnant patients, you must be, as I said, you should be prepared for intrapartum and postpartum hemorrhage. You must have a process of measuring the blood loss by weight, which is very simple. You can, methodology, it is very well described in many YouTube videos. So you must follow this. What I generally do is, of course, there is one more method, which is a Triton, which is more sophisticated. It uses the iPad pictures to estimate blood loss, but again, there is a cost involved. But what is more important is, two methods should be followed, and the two common methods that can be used are the visual method and the weighing method. And vigilance has to be exercised when there's a disparity between the two methods is more. In fact, I wrote recently a correspondence in Anesthesia Analgesia about how we generally make mistakes in the assessment of blood loss. When there is an ongoing blood loss, someone must gather information of blood loss at various stages of the management, in the operating room, in the post-operative room, antepartum, and make a good estimation of blood loss. And as I said, when there is a difference between the visual estimation and a method, like the weighing method, then you must exercise greater caution, monitor this patient carefully with serial labs and serial hemodynamic parameters. Then there is a prevention of coagulation derangement. Now, it is absolutely essential that we must prevent coagulopathy in an ongoing bleeding. Is that a better strategy? The answer is absolutely yes. The reason is, when there is coagulopathy, it is very, very difficult for the obstetrician to determine whether it is a surgical bleeding versus the coagulopathic bleeding. The obstetricians tend to think it is more towards coagulopathic, and the anesthesiologists tend to think more towards surgical bleeding. So if we prevent coagulopathy, at least you rule out, one factor from our management. Now, what happens to fibrinogen during obstetric hemorrhage and manage appropriately? Now, in this strategy of preventing coagulation or assessment of coagulation, we all have a set of laboratory functions which are available. Now, majority of the hospital has got the conventional labs like PT, PTT, INR, fibrinogen, CBC, etc. Some of the other hospitals may have TEG, ROTAM. But however, remember one thing, that there is a time lag of at least 45 to 1 hour in these processes to get results. So how do we assess coagulation quickly? Of course, this slide actually shows that we are a little fortunate at University of Maryland that we have the resources of TEG as well as ROTAM available to us for assessing coagulation. This is again a new version of a coagulation which uses ultrasound technology called as Contra. And this is actually a point of the care system, and you just take a sample as seen here, a blue top, and then load it up, and you get the results in about less than 15 minutes about the coagulation status of the blood. As I said, most of the methods currently available with us take time. So the easiest thing one can do, which is probably underused in clinical practice because we always go for sophisticated technology, we forget that a simple method can give us a great deal of information when we are in a crisis. And this is, you take blood in a red top and leave it there for about 10 minutes. And if the blood clots, that means between about 9 to 10 minutes, that means you know that there is no gross coagulation defect. If the blood did not clot, I don't think we have to wait for the conventional labs to come. You can check on the labs later and to see, and they will be deranged definitely. And actually, I did many times this versus the TEG. And at least what I found is when the blood clots well in the red tube, the TEG is most of the time small. So it's a good screening test for us. Now, and I call this as a poor man's TEG. So if you do this test, and if the poor man's TEG is also, if the poor man's TEG is normal, you can wait for the labs to see where your fibrinogen is. Your fibrinogen can be in the low normal range. So you can be more watchful about further bleeding. So once the tests are normal, now we should prevent coagulopathy to occur. That means you keep managing the patient with blood products. You don't want to lag behind and produce coagulopathy. But if the tests are abnormal, then you begin your transfusion protocol, whatever you think is appropriate. RBCs, FFPs, cryoprecipitate, fibrinogen, etc. So you transfuse. But don't give too much of fluids, and I'll explain why. So once you correct coagulopathy, you must prevent further coagulopathy from occurring. And maintain fibrinogen over 200. Now, what is the golden number of blood loss where fibrinogen is less than 200 milligrams? That's a very difficult question to answer. But however, there is a paper from Europe where actually this is a retrospective study of all blood losses in postpartum hemorrhage, where they studied the coagulations and the blood loss. And when you look at the fibrinogen table here, or the graph here, at about 2.5 liters of blood loss, the fibrinogen drifts around 200. So therefore, based on this paper, at least you have to be watchful if your blood loss is 2.5 liters or above, because the fibrinogen could go down. This is just to give you two examples. In the first patient above, there was a 2 liters blood loss, and the fibrinogen that was 390 fell down to 173. In the lower case, it was 1.5 liters, and the fibrinogen still remained high. But one thing that is very important is, in pregnancy, the fibrinogen level can vary from anywhere from 250 to 600 milligrams. As you can see, it was 591. So if someone has a high fibrinogen, they have probably a better safety margin when they have a postpartum hemorrhage. This compared to a patient where the fibrinogen is only 250 when you are starting, and then the patient has a postpartum hemorrhage or intrapartum hemorrhage, then the fibrinogen is more likely to drift. So because of this, when we are doing critical obstetric patients, for example, Eccrita or Parikh cases, we always get a baseline fibrinogen. Of course, we do understand that we don't get baseline fibrinogen in every pregnant patient. Probably it is not necessary because everyone doesn't bleed. But remember that if someone has got intrapartum hemorrhage and postpartum hemorrhage, the assessment of fibrinogen becomes extremely crucial or critical. Now, this is your usual coagulation status, or the coagulation pathway, I should say. And then there are two factors which we use, which is a recombinant factor 7A and also K-centra, which is prothrombin complex. And although you know these recombinant factors 7A and K-centra have a definite role in correcting coagulation, one thing that is very important is to have the fibrinogen level adequate. If your fibrinogen is low, giving recombinant 7A or K-centra, which is the prothrombin complex, which is 2, 7, 9, 10 factors, it does not make a difference because fibrinogen is the ultimate pathway that is important. Or the fibrinogen level is very important because fibrinogen is converted to fibrin, in the final coagulation pathway. So therefore, maintenance of fibrinogen is very, very critical in the management of postpartum hemorrhage. We did a study actually comparing the 1:1:1 transfusion protocol to the old conventional 3:1. That means 3 RBCs versus 1 platelets. 1 FFP. What we found was there was no difference between 1:1:1 protocol versus 3:1 as long as the platelets are low. However, if the platelets were more than 100,000, 1:1:1 is much more superior. So therefore, it is important. There is some evidence in the literature and also based on this in vitro study that in an ongoing hemorrhage, it may be wiser to maintain platelets over 100,000. Then the final thing is the critical management factors. That means there are certain factors, ancillary factors that are very, very critical in the final outcome or a success in a given intrapartum or postpartum hemorrhage. Now, increase in, as I said, in pregnancy, there is a increase in blood volume, cardiac output is there, increases, there is a relative anemia. I refrain from giving too much of fluids because it activates the fibrinolytic mechanism. And secondly, it can also produce dilutional coagulopathy. Now, when you look at this, Starling's equation, the Starling equation is towards pulmonary edema in pregnancy. Now, when you see the oncotic pressure, normal, this non-pregnant patients is about 24. And this decreases to about 19 in pregnancy. And if someone has pre-eclampsia, it further decreases to 17. Now, when you give fluids, the Starling's equation is actually towards pulmonary or interstitial edema or pulmonary interstitial edema. So when you are giving fluids, they're likely to get pulmonary edema, particularly when you are giving too much of fluids. So that is why I said you have to be a little watchful, giving excessive fluids when you are managing intrapartum or postpartum hemorrhage. HSPAN is not a very good choice. The reason is it may interfere with coagulopathy. And so it's probably better to limit it to about 500 ml. Then there is what is called as a triad of death: hypothermia, acidosis, and coagulopathy. They are very much related because hypothermia produces acidosis, acidosis produces coagulopathy, coagulopathy produces bleeding, so it produces again hypothermia because you are giving a lot of blood, fluids, etc. So therefore, it is essential that you prevent acidosis, you maintain the patient's body temperature by using some sort of an external mechanism like bear hugger, etc. Then there is something called as what I call as the cord of death, where it is a calcium. That means where hypocalcemia can also increase bleeding, and therefore it can produce coagulopathy. Therefore, you have to maintain calcium levels in the blood. Then the last factor is, of course, is monitoring. You must have an arterial line, adequate intravenous access. If you are going to do these cases more often, it is better to have one method of measuring cardiac output, either using arterial line or using a non-invasive method. There are a couple of non-invasive cardiac output monitors which are fairly reliable as a trend monitors. Then monitor the temperature, and if the patient is under general anesthesia, don't forget to use carbon dioxide end-tidal CO2 as surrogate of cardiac output. If end-tidal CO2 decreases for a given ventilation, you know that the cardiac output is decreasing. Then frequent labs, and of course EKG monitoring, particularly to rule out hyperkalemia. Then everyone must be familiar with aortic compression, bimanual proximal external aortic compression. This is probably very critical to tide over acute crisis, particularly when you compress aorta and you have little time in actually building up the patient's blood volume for ongoing surgery. So obstetricians must be familiar how to compress the aorta, and anesthesiologists as well. This is just a picture to show the aortic compression. So how do you conclude, or what are our conclusions? Postpartum or intrapartum hemorrhage in pregnancy is unpredictable. Prepare yourself. When hemorrhage occurs, don't panic. Start communications, know your backups, call for your backups. Have a protocol for obstetric hemorrhage and initiate the protocol. Then mobilization of help is critical for the final success. And then if you're in a smaller hospital, you must consider transport to a different institution before an acute crisis occurs. If you are already in a crisis, then make all arrangements to prevent further bleeding. And then you have to transport this patient with continuing resuscitation. There is actually a good paper recently published in the New England Journal of Medicine and on postpartum hemorrhage. It is a review article, and it summarizes pretty much everything about intrapartum and postpartum hemorrhage. And I would recommend all of you to read this paper. Thank you.
Thank you very much, Dr. Kodali, for that simple tips which you have given us to manage an unexpected postpartum hemorrhage. And now, since Dr. Kodali is a very busy head of the department, he has many meetings lined up. So we will take questions. And we had carried out a survey through our postgraduates all over the country. And there were many questions which they wanted Dr. Bhavani to answer. So Dr. Bhavani, can you just project that slide so we will know about the questions?
Sure. Can you see this slide now?
Yes, sir.
Okay. So one of the questions that came was that viscoelastic assays are supposed to reduce transfusion of blood and its blood products, but this is possible only in resource-rich countries and abroad. How can we know early? I think I answered this question in my talk about the poor man's track. Even at University of Maryland, we have all those viscoelastic tests, I still rely on this. And I tell every resident, just do this quickly and see where we are. So you can do that. And also you can look at where the bleeding is coming from, not only from the surgical side, but the non-surgical sites, particularly the skin and the incision site. If the patient is oozing from there, then it is more likely to be a coagulopathic. So you can use some of these methods and your observations to figure out what is happening in a given case. The second one is actually wants to know that why the mortality rate is higher in the United States compared to other countries like Australia, UK. You are absolutely correct. The reason is in the United States, some of these surgery, some of the intrapartum, postpartum hemorrhages occurs in community hospitals, and they are not geared to manage those patients. And that is why this obstetric bundle is being educated across the United States to almost all centers wherever pregnant patients are taken care of. So that is it doesn't mean that the hemorrhage doesn't occur in the United States, and it is also one of the causes of bleeding, mortality here. Then the next one comes from Ajmer. And first of all, I have to congratulate this team of this managing this case very well. It was 130 kilos, morbidly obese patient, 2 previous sections. I don't think there was a placenta previa in this. It was not mentioned. The ultrasound examinations done 3 times was normal, and the spinal anesthesia was given. And on opening the abdomen, they found placenta accreta, percreta extending into the bladder. Profuse bleeding occurred, and baby delivered, patient collapsed, patient intubated, and they gave blood, ICU transfusion, etc. And ultimately, the patient did very well. So the question here is, how should we have prepared ourselves? I have already answered. Postpartum hemorrhage or intrapartum hemorrhage is unpredictable. If we are doing obstetric cases, we have to be prepared for that. Second, although this patient is obese, the technique of ultrasound technology has improved so much that they should have picked up this percreta, particularly that is extending into the bladder. It is anterior, so it is extending into the bladder. This could have been probably, could have been picked up by either transabdominal or through the vaginal ultrasound. Actually, I did discuss this case with some of our obstetricians also. We have a very good service here, so we follow these cases very, very carefully. We also do in a suspected cases MRIs also. Then this last case, the last question is: so all cases of PPH receive fibrinogen, and I explained that it is very difficult to predict at what level the fibrinogen is going to depth, because it all depends upon what is the preoperative fibrinogen level in a given case. But however, if the bleeding is occurring, if the blood loss is more than 2,500 to 3 liters in a given patient, particularly in India, you have to be careful because your BMI of our patients is actually low. So if they lose 3 liters of blood, it will be a substantial loss of blood. I think you must think of fibrinogen at that stage. And there was one question about in chart box is about steroids. Normally, we don't give steroids in case of a hemorrhage, but she said prolonged hypotension. Probably you can give steroids, whatever help it can, it will do, and also probably may protect against cerebral edema also. But as I said, it is not one of the modalities of treatment. It is mostly how we manage the blood loss and how we manage the transfusions. I think those were the questions, Dr. Sunanda.
There is another question where they want to know the role of tranexamic acid. Should it be given empirically or it should be given compulsory?
Yes, actually, I will show you this slide. Tranexamic acid, as you know that, it's one of the modalities recommended if the blood loss is over, a liter. Now, this was a study that came in the New England Journal of Medicine very recently, where 4,000 patients were randomized to receive tranexamic acid and no tranexamic acid prophylactically. And they found that the postpartum hemorrhage, as they defined in the study, is about a liter. and it was 27% in the tranexamic acid group and 31% in the placebo group. And there was no difference in the gravimetrical estimation of blood loss, at least in this study. But when you look at the thromboembolic events, it is 0.1 versus 0.4. That means tranexamic acid had more thromboembolic events, although it was not statistically significant. But what is more important is the BMI in the study group is only 26. And at least for us, we deal with our BMI average is 45 or 40. So, and they are already thrombotic. So that is the reason why we use tranexamic acid after the baby delivery if the blood loss is over a liter, or soon after the baby delivery, we use tranexamic acid in a patients where we think that there is already a risk of high platelet. So we are a little bit of selective and not use indiscriminately tranexamic acid. That is what I do at least.
Yeah. There's another question, sir, which says, how does aortic compression help? And how do you do aortic compression? He wants to know.
Sure. Actually, the best thing what I tell the obstetrician is just put the hand on its abdomen is open. Although we can compress from externally from outside, probably it's easier to give an internal compression. In fact, recently when I was, one of my colleagues said, the blood pressure went down to 60 soon after the baby delivery. And I was trying to give all the boss. So I said, why didn't you tell the obstetrician just to compress the aorta? And immediately the obstetrician turned. He's a very good, obstetrician who does a lot of accreta percreta. So he said, oh, well, you should have told me I would have just compressed the aorta. See, once you compress the aorta, it gives you time to actually build up your volume, put an extra line, and also it decreases the bleeding. Now, when you call your backup surgeons, say a vascular surgeon, in a big case of bleeding from the uterus, the first thing they come is cross-clamp the aorta and say, okay, the bleeding has stopped now, just build up the volume and then we tackle the hysterectomy or whatever it is. So I think everyone should be familiar with, and I know one group in Hyderabad has done a study where the anesthesiologist give the external compression and in a cases of percreta surgery, and they found that actually the patients require less blood transfusion. And Sunil Pandya probably will have a better idea on that particular study.
We'll be having him in the question answer session, sir.
Sure.
Another question is, are there role for antifibrinolytic agent used in the management of PPH? If any, what antifibrinolytic agent is best for the management of PPH, he says?
One is, of course, we are using tranexamic acid, right? That is one of the things which is good to use. Actually, I was a little surprised. Tranexamic acid has been used for a very long time in India and across the Europe, even 70s. In fact, when I was doing my residency in late 70s, we were using it. Somehow in the United States, it fell apart, and but then again, the big study that came in the New England Journal of Medicine about this postpartum hemorrhage, the rest. So I think tranexamic acid is probably is a drug of choice. I think it's easily available. But again, a word of caution out of the blue, tranexamic acid looks like a spinal ampule, and tranexamic acid has been given as a spinal anesthetic with complications. So that is something that has come up recently because we are using more TXA during pregnancy, cesarean sections.
What is the role of fresh whole blood transfusions?
Now, what's the question, ma'am?
What is the role of fresh whole blood transfusion?
So the fresh blood transfusion, probably the fresh blood transfusion is always better because it is, it has got all the factors which are very, very viable. But again, the question is the question of transmissible diseases. So that is why still it is not, the standard of care. But I believe it is done in some countries where when the blood becomes necessary and they just get the blood from the donors and give. And the whole blood is probably much better than giving the products, at least because it has all the products, it has the RBCs too. But however, majority of the countries prefer the component transfusion to risk the, transmissible disease, transmission.
And plus fluid overload is also a concern.
Exactly.
And of course, you see that in your Bollywood movies, the fresh whole
Right.
blood transfusions.
Yes, absolutely. The blood going straight from the patient from one to the other.
Another question comes is, what is Hespan? What is the pharmacological name?
No, Hespan is hetastarch, actually, starch, and it is actually available in many countries. And it's a good, it used to be a very good blood volume expander. But again, it is associated with some sort of, the coagulation derangement when it is given excessively, and also it can alter the kidney function. And the kidney function gets altered when a patient is hypotensive and hemorrhage. So that's the reason I said limit to 500. But again, if you are tied up with no blood and you need to keep the volume, then of course you give it. And then you have to also understand what are the consequences of giving. So I think Hespan or Hetastat is available in India too.
Yes, it is available. Then Dr. Muralidhar Kanchi wants to know, how can IV fluids activate fibrinolysis? Do you use Hespan?
No, actually, as I said, we don't use actually Hespan at all. My preference is to use albumin. I stocked actually albumin in all ORs where we do pregnant patients. Because the reason why I use albumin is, number one is it may not interfere with coagulation. That's number two. Number one. Number two is, as I said, the oncotic pressure in pregnancy is already low, and pregnant patients have gone into pulmonary, they go into pulmonary edema very, very quickly. And anyone who is an obstetric anesthesiologist must have seen how that pulmonary edema, when it occurs, the fluid just comes out of the endotracheal tube as if the IV fluids are connected to the endotracheal tube. It is really, we can't forget that scene. And that's the reason why I normally prefer albumin to keep the oncotic pressure.
What about interventional procedures to control bleeding?
So absolutely, the interventional procedure to control the bleeding is a very good option. Now, in fact, we used to do cesarean sections in the hybrid rooms itself by putting the balloons in a known cases. You can inflate the balloons after the baby delivery when there is a hemorrhage, and then they can do whatever procedures they need to do, or they can embolize it. They can do the embolization. Then the obstetricians can look at if the success of the embolization has occurred, then close the uterus and the abdomen. However, the IR procedures are associated with limb ischemia. So that is why some obstetricians and clinicians do not prefer. And here actually we don't do IR routinely, but we keep the intra-aortic balloon, balloon ready for certain cases, and the vascular group is available to put the balloon immediately and then deploy the balloon if there is a bleed. And also in some cases, we have left the uterus without taking the placenta out and did the, formal hysterectomy about, within 6 weeks. But leaving placenta inside is a little bit of a problem. Patient can still get pre-eclampsia. So we have to do an emergency cesarean, we have to do an emergency hysterectomy where we left the placenta because of the patient was developing pre-eclampsia.
So do you give methotrexate?
The placenta? No, methotrexate is one of the options. I don't think the 3 or 4 cases where the methotrexate was given. They just left the placenta and then did it after about 4 weeks or so. But that's a good option, though.
One of them wants to know, have you heard about Panikker's cannula for PPH? It is known to stop or avoid PPH.
No, I don't know that particular one.
And how much albumin do you give?
Oh, normally I give about 500 to 750 ml, I mean, straight away, by the time I get the blood.
Okay. And do you have artificial blood available?
No. In fact, I did one of the reviews on this subject long time ago, about 10, 15 years ago. At the time, it was associated with more kidney problems.
Okay. So, Dr. Kodali, that was a really very, very explicit and lucid talk, and you answered all the questions for us. Thank you so much for taking time out from your busy schedule. It's a pleasure to have you every time. And Baltimore is our next visit the moment Biden opens up the flights.
Sure.
Okay. Thank you, sir. Thank you.
Thank
And
you.
stay safe.
Thank you.
So now we have our next speaker today, who is Dr. Purva. And Dr. Purva is the president, the chief director, consultant of Hull University, UK. And she's the founder director of simulation at Hull Institute of Learning and Simulation. She's president of the Association of Simulation Practice in Healthcare, president of the Yorkshire Society of Obstetric Anesthesiologists. Sanish, can I please have the slide? She has received many leadership awards, and she's an honorary reader at the Hull Medical School, and she's also a joint editor of the Metric Journal. In UK, as you all know, UK is in the throes of a severe pandemic at present. So Purva is busy with some meetings, so she sent her slides over, but she has promised to join us for the question answer session. Over to you, Purva. And she will be talking.
Hello, everyone. I'm Dr. Makani Purva, an obstetric anesthetist working in Hull University Teaching Hospitals NHS Trust. Thank you for giving me the opportunity to talk to you today about pre-eclampsia and new insights. So I'm going to start by sharing the presentation. Okay. So I have roughly about 20 minutes to talk to you about new insights for the anesthesiologist. And I'm going to start off by first looking at what objectives I'm going to be addressing on this presentation. So I've got three objectives. One is to provide an overview of pre-eclampsia management. The second is to focus on aspects relevant to anesthesiologists. And the third is to review best practice and highlight new insights. It's conventional for most presentations to start with a look at what is the incidence of pre-eclampsia. So now this is a very interesting set of statistics, and it has come from the National Health Portal in India. And I was quite impressed when I went into the portal and saw the level of detail and information that was available. So the incidence of pre-eclampsia in India is reported to be 8 to 10% amongst the pregnant women. And the prevalence of hypertensive disorders of pregnancy was 7.8%, with pre-eclampsia in 5.4% of the study population in India. So it still remains a very important issue, and quite an important issue in terms of maternal deaths, where 1/2 or 1/10 of all maternal deaths are associated with hypertensive disease of pregnancy. So if you look at the definition of pre-eclampsia, the definitions are as you would expect. Nothing much has changed But just a refresh, elevated blood pressure in pregnant women with previously normal blood pressure being greater than 140/90 on 2 occasions, 4 hours apart, or greater than 160/110, and proteinuria as identified by 24-hour urine, a protein creatinine ratio, and urine dipstick. Now, what is interesting with preeclampsia is there is a bit of a continuum. It's a dynamic process, starting with gestational hypertension, preeclampsia without severe features, and then severe features where you have all the elements, including the dysfunctions with organs and HELP syndrome, and that entire spectrum is there in when you look at hypertensive diseases or pregnancy. So if you actually look at what is the management of eclampsia, it is important for us to look at what impact it has had on the mother and the baby worldwide. Preeclampsia remains a problem across the world. And one of the big problems is when you start with management is that you've got to start with the patient. How well do they understand the disease? How well do they how well are they aware of this issue, and how well they are aware of the symptoms so that they can highlight it to their obstetrician or midwife or their carers. So I'd like you to look at this very interesting foundation, the Pre-eclampsia Foundation. Many of you may already be aware of it, but for those of you who are not aware of it, I would urge you to go and visit it. It's essentially a collection of stories looking at the personal stories of mothers who have been through preeclampsia. Some positive, some quite sad in the sense that they've lost their babies and had some very dramatic changes to their lives. And the one that I was recently updated was about case 7, and it is the story of this young mother who shares the story of their miracle baby. It was a happy outcome, but there are lots of stories like that. So the Pre-eclampsia Foundation aims to provide a lot of resources, especially to the public, to mothers, so that they can be better forewarned and equipped. And the Royal College of Obstetricians and Gynecology in the UK also provides information. So having a look at this, and as anesthesiologists, we come across patients, and it is very important for us to be able to share the appropriate resources as well. So I would urge you to have a look at that. If you look at obstetric management, there is clear guidance from NICE, which is the National Institute for Health and Care Excellence in the UK, which looks at how you manage them antenatally and how you manage them in terms of their birth, so intrapartum, and also what are the medications that you would look at depending upon whether they were in hypertension or severe hypertension. And much of this, I think, it's quite clear. So whether it starts with looking at ensuring that you have adequate antenatal care. And this is where I think as anesthesiologists, where we get involved in pre-assessment clinics, where we do joint clinics with obstetricians, we need to be aware, because we need to be able to identify those initial signs and be aware of the risk prediction tools which are used to identify preeclampsia. And one of the things I feel as anesthesiologists, we need to speak the language of our obstetricians in order to be able to then act as equal stakeholders in the care of these patients. And again, if you look at antihypertensive treatment, the use of labetalol and nifedipine, methyl-dopa, each of them has risks. We need to be aware of what medications are being used. We need to be familiar with how they're being used. And again, the mode of birth is important, because when many times these conversations happen antenatally, sometimes and many times happen intrapartum, and we need to be there at that table having those discussions, because an early birth, a planned birth, with all the stakeholders involved will provide you less surprises and less problems as well. Now, what is important here is that there is a joint decision that is made to planning the birth, because you want to be in a place where you can actually avoid an unnecessary general anesthetic. And that is why it's important that you're part of that discussion. the important aspect of the preoperative optimization of patients is also comes into a place where anesthesiologists can help decide for the obstetricians, and perhaps we can discuss how we can better provide an anesthetic technique which would be more appropriate for the pre-eclamptic patients if we have certain gadgets in our within our abilities to use. One of them is ultrasound. Now, if you look at new insights in pre-eclampsia or eclampsia, one of the big things that is emerging in our literature is the use of ultrasound, whether you use it to look at the optic nerve sheath diameter as an indicator of raised intracranial pressure in pre-eclampsia, or whether you're using the lung ultrasound to predict interstitial syndrome and hemodynamic profile in parturients with severe pre-eclampsia, or whether you use cardiac ultrasound to help you with the hemodynamic monitoring. It really does seem that ultrasound echo is emerging in a big way. And that is why I think as the next generation of obstetric anesthetists, our role will be just not in doing that spinal and that epidural or doing the GA, but it is also to develop a certain degree of capability and ability to be able to use these elements as part of our wider practice. Obviously, you can't use it for the first time in a pre-eclamptic patient. It's about using them regularly, routinely. I think is very important. And identifying somebody who's lead, I think will be very important, because they could go for the specific training, and then they could cascade this to everybody else. As I alluded to earlier, planning birth is very important, and being part of this conversations is very important. Now, early neuraxial analgesia is very useful. Having an epidural in place will avoid that unnecessary GA. The same risks that you would talk about for any obstetric patient applies, but this is even more exaggerated in pre-eclampsia. So all the issues that you would have in terms of upper airway edema, failed intubation of 1 in 300, becoming even more important in these patients, upper airway anatomy being compromised. There is an issue with having to avoid the general anesthetic, especially with the induction, where you will have the huge swings with the blood pressure. So you would want to avoid GA as far as possible. There's always been this concern whether epidural or spinal, which is the preferred method. So neuraxial analgesia, if given early, can reduce the need for providing spinal. It can also provide a better intrapartum physiological profile for the patient, avoiding the big fluctuations in blood pressure that you see with pre-eclampsia. So early epidural is very, very important. However, spinal anesthesia, I remember at a time when I started off in obstetric anesthesia, spinal was a no-no, partly from the fact that spinals could cause a severe drop in blood pressure. The sympathetic and the parasympathetic changes were used as a reason why you would avoid it in pre-eclampsia. But what evidence has suggested that it remains a very reasonable anesthetic option for cesarean delivery in severe pre-eclampsia. And in fact, they have less severe spinal-induced hypertension. And therefore, if appropriately treated, and if you have the right agents in place, spinal anesthesia is a very good method of providing an anesthetic for an operated delivery. The reason why we talk about operated delivery is that there's always been this concern on whether you're going to do a vaginal delivery or an operative delivery. The chances of an operative delivery are very high in pre-eclamptics, especially if they've come into labor. And depending upon the various metabolic derangements, the obstetrician is likely to opt for an operative delivery so that it can be done in a more planned way. So be prepared that while you may have a neuraxial analgesia and hopefully you will do vaginal delivery, having a sudden change in the course of action and an obstetrician opting out for an operative delivery is highly likely. So you must be prepared to either top up your epidural, or if it's not there, to have a spinal anesthetic in place. Using the same vasopressors as you would normally use, but perhaps a smaller amount is what is required. The usual question of what sort of blood pressure that you should aim for, basal blood pressure is what you would aim for, provided, of course, it's not too high, and therefore you assume a more appropriate level of blood pressure, which will be relevant for that particular patient. So if you were in the unenvious position of having to do a general anesthetic, either because there's no time or there is the spinal and the epidural is contraindicated because of, let's say, thrombocytopenia or other derangements, then the two things of caution there would be prepared for huge swings in blood pressure. So have a pre-induction arterial cannula for continuous blood pressure monitoring. And remember, you can add drugs, especially to the induction, including esmolol, nitroglycerin, remifentanil. Now, all of this, make sure that when you do it, especially if you're junior, you have senior help, you ask for early senior help. There is some sort of a plan on how you're going to do it. The worst thing to do it is to come up with these medications beforehand. My suggestion would be that the entire team should be better prepared. There should be simulations of how to manage the severe preeclampsia and a GA, and there should be protocols. And I'm going to talk a little bit more about protocols later. So the fluid management is a key aspect that I think as anesthesiologists we will get involved in. What are the new insights? I think nothing much has changed over the years. It is very clear that it remains to be, it should be a restrictive way of management. CVP is not a good way of assessing the fluid status of a patient. The restrictive review of the recent literature continues to uphold a restrictive approach, but more importantly, an individualized fluid management based on certain markers of end organ perfusion, such as urine output, mental status, pH, and lactate, using point-of-care bedside ultrasound examinations that I previously alluded to, the lung ultrasonography that I spoke about, and transthoracic echo. So all of these are very useful for you to decide how much of fluid to provide. So not using CVP, but using these more modern techniques is important. But again, the usual question, crystalloid versus colloid. Nothing much has changed. There is no a clear guidance on which is better. In a systematic review, looking at evaluating crystalloid versus colloid, looking at the outcomes of pulmonary edema, perinatal mortality, preterm birth, and cesarean delivery, the authors found insufficient data to make a final recommendation. So that came out of this review, and if you're interested, please do read the article as well. Postpartum, most of us heave a sigh of relief when the patient leaves the theater, but it is important to recognize that the journey is not over, because many patients will have symptoms, sometimes no symptoms in the antenatal period, intrapartum period, but they may have it for the first time in postpartum. Or if you have a patient who's behaved well on the table, might suddenly develop headache. So important to have a differential diagnosis, important for you to recognize that there may be other sinister pathology as well. You also have the issue of press as well coming up for the first time. So making sure that you have access to scanning facilities in the place that you are, and you also have the right people who can interpret these scans. Continue to focus on blood pressure control, because that can go completely out of hand in the postpartum period. Anti-seizure prophylaxis is really, really important. Magnesium is the one big thing that has made a huge difference to pre-eclampsia. I mean, there is Cochrane reviews have demonstrated that if there's anything that has changed in the last 20 years with pre-eclampsia, it is the use of magnesium. And again, as I said, always have a lookout for signs consistent with pre-eclampsia, so high index of suspicion. And then, of course, ideal location. Where do you look after these patients? Especially if you've had a stormy interruptive course, it's not rocket science. Intensive care unit admission is appropriate. But the problem really comes is where you do not have a case where you're not sure about whether this is pre-eclampsia or not. So have a low index of suspicion and make sure that you involve your intensivists, involve your obstetric colleagues so that you make the right diagnosis. Many of the issues that have come up in the mortality reviews, and as you know, the UK is very good with their maternal mortality reviews, has highlighted the delay in the implementation of therapy while awaiting treatment. So you might have that ICU bed, you might have the HDU bed, the patient with that borderline blood pressure issues is left alone in their bed, and then they develop seizures and they have a fatal outcome or an unfavorable outcome. So remembering that it is really, really important to be aware is really useful. Now, I've shared with you some very useful guidelines, which is available on the OA website, which is pre-eclampsia, eclampsia. And these guidelines are what you should be looking at in your organization. So I want to end with a very, very useful statement, which I came across on the Pre-eclampsia Foundation website. And what it said was, we envisage a world where hypertensive disorders of pregnancies no longer threaten the lives of mothers and their babies. So what I would like to conclude with is a plea that the best practice, the evidence is available there in the literature. What we need to do is to work as a team to develop shared protocols that we can all practice and be ready for long before the patient arrives in our labor ward. Thank you very much for your time.
Thank you, Purva. And we'll have you for the question answer session in the end. So now we go on to the next lecture, that is Pearls of Airway Management in the Obstetric Patients by Dr. Kajal Jain. She's Professor PGI Chandigarh and a course coordinator for DM, Trauma Anesthesia and Acute Care. And she's also the Honorary Secretary of AOI, and her special interest is trauma, obstetric anesthesia, and organ transplant. She has a lot of publications, awards, and chapters, and recently she organized the first international webinar of AOA in January 2021. So over to you, Dr. Kajal.
Thank you very much, ma'am. I will share my screen now. Today is a holiday for most of us, and it's Eid. So I wish everybody, whosoever is attending this webinar, a very happy Eid celebrations today. So we move on to the third topic today, that is Pearls of Airway Management in Obstetric Patient. We have heard very important talks on pre-eclampsia and hemorrhage, and there's a third one which I feel is very, very important. So as I go further, I would like to just bring out a disclaimer that I have taken some material from Dr. Anju Grewal's slide, who is a national speaker in AOA, and she has been speaking on this particular topic all over India in various conferences. So I thought it would be a good idea to catch some slides from her PPTs to make it more meaningful for you all. And this is Dr. Mary Moshambi. Mary Moshambi happens to be the backbone of difficult airway management in obstetrics. She comes regularly for our AOA meetings, and this slide is from the webinar Madam Sunanda just spoke about. She spoke on difficult airway in our webinar too, so I have taken some cue from her slides as well to make it a very enriching experience for you all. And of course, some images are from the Med Twitter and Facebook blogs, so which I haven't really captioned, so that's it. So we move on. So we know that maternal airway is very important because there are certain concerns when we secure the maternal airway. And let's see what are those concerns. The concerns are that there's a high incidence of failed intubation because there is a general belief that maternal airways are difficult. So what is failed intubation for a maternal airway? It is the inability to secure the airway with 2 attempts which includes the best attempt in intubation using conventional laryngoscope or use of an alternative airway device to assist tracheal intubation. So the incidence of failed tracheal intubation in obstetrics is very high. It is 1 in 390 to 443, whereas in a surgical patient, it is very less. It is 0.045%. So that is why this makes it a very concerning issue for us all. So after failed intubation, there is significant amount of morbidity. This is a 2-year national case control study in UK, which was published in 2013. And here the authors, they have shown us that after failed intubation, the maximum morbidity happens due to hypoxia, which is about 71%. And 40% is the lowest saturation recorded. 8% of the patients aspirated, and there were many neonatal intensive care admissions because of maternal, maternal non-well-being. So about 34% of them had to be admitted to an ICU, as opposed to an uneventful GA. So therefore, looking after maternal airway becomes very important. So why is pregnant airway difficult? So pregnant airway is difficult because there is an altered anatomy. We all know there is weight gain, because weight gain, there is a enlarged breasts too. Because of these two reasons, there is a difficulty in optimizing your head and neck position, and there is less place to open the mandible and insert the laryngoscope blade. On top of that, as the pregnancy advances, due to fluid retention, there is airway edema. And of course, with full dentition put together, constitutes an altered anatomy. Along with that, there are certain physiological changes like decreased FRC and increased oxygen consumption, decreased lower esophageal sphincter tone, which poses difficulty in accessing a pregnant woman's airway. So airway edema happens due to, hormonal changes like increase in estrogen and increase in blood volume, which causes capillary engorgement, mucosal edema, and tissue friability. So this all leads to, when you manipulate the nasopharynx, it causes bleeding. Due to enlarged tongue, there is difficulty in displacement during laryngoscopy, and the larynx anatomy can similarly be distorted because of capillary engorgement and mucosal edema. So we need to have a smaller size tube with us. So you have just heard Dr. Bhavani. Well, Dr. Bhavani has also told us that airway changes occur during labor also. So this was one article which he published in year 2008, in which he showed that airway, there's a class change in Mallampati from pre-labor to post-labor in a normal laboring women. So we have to be very upfront if these women come to us for general anesthesia, and these changes do not revert to normal even till 48 hours of postpartum period. So whenever you have to see a patient in a postpartum period, you can also have a difficult airway. So the relevance of these airway changes should also be kept in mind. So, airway edema also worsens in certain conditions, and very importantly, pre-eclampsia, hemorrhage, and resuscitation. So I'll give you two, evidence-based, publications for pre-eclampsia and hemorrhage and resus. Of pre-eclampsia, the study was done in my own center, and here I was one of the authors. So here we saw the airway changes following labor and delivery in pre-eclamptics, and we saw that the Mallampati score increased from pre-labor to post-labor period in both pre-eclamptics and normotensives. However, when we performed an airway ultrasound at the beginning of labor, we saw that tissue thickness at hyoid level was higher in pre-eclamptics. And importantly, we have to also remember that most of the pre-eclamptic women, if they undergo cesarean section, it is mostly, after shorter labors. So a class change in Mallampati after shorter labors should also be kept in mind when you're looking at pre-eclamptic patients. This is again Dr. Bhavani's article, in which he has found that if you are having a patient on table who is undergoing peripartum hysterectomy, and she receives a lot of fluids, about 2 to 8 liters of fluids and lots of blood, then she is also susceptible for developing tissue edema as a result of intravenous fluids. So if you for example, if you started a case in, spinal, and now you want to convert it to GA, you may end up having a Malampatti 4. Or if your patient comes for re-exploration a day later, patient may have, Malampatti 4. So these are the kind of airway changes you can encounter not only in an elective patient, but also in emergency scenario. So talking about physiological changes, there is decreased functional residual capacity. And we have seen from a non-pregnant woman to a term pregnant woman, the FRC decreases by 15 to 30%, and it worsens if the woman lies supine. So 30 to 50% of parturients have closing capacities more than FRC. And this further worsens if the patient is obese. So we have to keep this into mind when we induce these patients. And then there is increased oxygen consumption because of the presence of the fetus. And then there's a placental oxygen demand, which increases to 20% at term and further increases to 63% with painful contractions. And in our country, where most of the women are not receiving labor epidurals, this is quite significant. So we need to understand that these women put together with decreased FRC and increased oxygen consumption, they give you a very less apnea time. This apnea is created when we induce and we give a muscle relaxant. So normally duration of apnea without desaturation should be tolerated, and if it goes below 90%, patient is hypoxic. So this time is significantly reduced in obstetric patients. And not to miss, there is something more also. We all know that most of the time general anesthesia is given for category 1 sections, or if you have a failed neuraxial analgesia and you have to rapidly acquire that airway, there is an increased performance pressure. The obstetrician is standing at your head end and looking at you to, immediately give GA so that they can proceed. You have decreased time for optimization like pre-oxygenation and positioning. It depends where you're working. If you are in a private nursing home or a small setup, you may not be having all kind of equipment availability, and the time of the day may not be very, very, suitable for us at that point of time. The level of expertise also depends. What is the level of expertise of the handling person? Because it has been seen that 80% of failed intubations occur with junior trainees. So put together, all this causes difficult intubation and leading to failed intubation. So how should we prep the maternal airway? So maternal airway should be prepped with, first and foremost, airway assessment. So this came to us from the 4th National Audit Project, which highlighted the major complications of airway management in UK. And this project told us that poor airway assessment contributes to poor outcome. So it's very, very important to make it a part of the overall plan for anesthesia. Say if you're planning only for a single shot spinal, you should not just go into the theater thinking it's just one single spinal and I don't need to look at the airway. We should always assess airway as a part of anesthesia. And in fact, we should even go ahead and do antenatal anesthesia consultation in high-risk patients, and evaluate airway on labor floor after admission also, because it has been seen that Malampatti class change can happen from 12th week onwards till 38 weeks due to fluid retention. So it is not it's not very uncommon to see a class change in Malampatti in these patients on the labor floor. So this comprehensive list is the same as for non-pregnant patient. More important is to recognize the difficult airway with the non-reassuring findings and have a plan in place. Having said that, there are some new predictors of difficult intubation on an obstetric patient, and this study has come up only recently in Trends in Anesthesia and Critical Care. Here, the authors have found that if the neck circumference is more than 39.5, and the chest circumference is more than 97.7 centimeters, with a weight gain of more than 11.7, these can predict a difficult intubation in a patient. So we have to assess each and every patient as per different predictors of airway difficulty. If you find that this woman has anticipated airway problem, then you should, even if the woman is low risk, say for example she's a primi gravida, but she has some risk factors to suggest difficult airway, you should not follow the normal intervention pathway. You should have a multidisciplinary approach, discuss the management. And if you feel you're in a setup where you cannot look after the obstetric airway, please refer the patient to a higher center. It's always important to identify and assess the airway problem and refer the patient if you can't do the case there. However, if you feel that you can manage, then you must always ask yourself, if this woman comes out of office hours, say late evening or early hours of the morning, do I have enough, clinical characteristics which are acceptably of low risk? Do I have the equipment, and do I have a personnel, and do I have a backup plan? If yes, then you can, consider, going further. If no, then you should plan for the elective C-section or regional anesthesia, which if fails, then you have to go according to the difficult airway guidelines. So can safe airway management be achieved after induction of GSA? If it's an anticipated difficult, it's not always possible, but you have to consider certain factors. Like if there is a patient has got a low risk for difficult mask ventilation, low risk for, supraglottic airway placement devices, or low risk for intolerance for apnea, regurg and aspiration, then you may, mark the cricothyroid membrane with ultrasound and go ahead with GA. But if you think these things are very, very difficult, then it's a planned case, then you might as well go in for awake tracheal intubation, because you have already anticipated difficulty here. You should have flexible bronchoscope, direct video laryngoscope, your supraglottic airway devices, and front of neck procedure in place. Also important to know is that most of the category 1 sections, which are indicated due to fetal compromise, one should always lay stress on intrauterine fetal resus methods, which include switching off oxytocin, giving a left lateral position, giving 100% oxygen, giving fluids, maintaining hemodynamics. And if the patient is having uterine tonus, then you can, break the tonus. What happens is it just buys you time. It reduces panic. There may be a chance that now your airway, you're given time to perform a neuraxial block, and it may even prevent GA. So if there is time and it allows, please have a look at this too. So what is the algorithm for safe obstetric general anesthesia? This has been given by the DAS in association with OAA in 2015. And here I will first focus on the first box, which says pre-theater preparation, in which we have already discussed airway assessment. We all know that we need to ensure the fasting status according to the current guidelines and give them antacid prophylaxis. And I've told you about the IUFR methods which we should employ. Now, next, I would like to just tell you how you should be preparing your, theater. So many times I have encountered this problem in my own setup, that you go, everything is there, but people do not know in which, drawer what is lying. So you have to know where is what lying. And if you can make, something like this with, icons, with face mask, supraglottic, because in urgency, the cognitive loads are very high, and one forgets that supraglottic airway device is just at the back in the trolley. So it's very important to know your theater personnel, and regular checks should be done for the same. There's a WHO surgical checklist, which is modified locally for C-sections. We have one for our own center. So wherever you're working, you should make your own checklists. And then you should discuss the clinical details of the case and current urgency category. You must have a second person on call who should be knowing about the clear procedures. Again, you should know what airway equipment your hospital is having. And you should be very familiar with the content of the difficult airway trolleys and carts, as I've just highlighted. Basically, this whole thing emphasizes on the teamwork, communication, technical skills, planning, and decision makings. Much of the problems will be solved if this is taken care of. Just as when we have to go out for a holiday, we take a rapid check on whether I have my tickets, whether my luggage is ready, and now it's only 1 week to go. Similarly, we must also have a rapid sequence induction checklist. This is one which I've picked up from the NHS of Northwest London hospitals. They follow their checklists, like when the prepare the patient, what should be done, then how should you prepare the equipment, what is the comprehensive monitoring, and how have you prepared yourself for difficulty. Now going ahead with the second box, which says when you do rapid sequence, as we have already checked our equipment, we should also know what is the position, what is our pre-oxygenation technique, with what am I going to induce the patient, what muscle relaxant am I going to choose, and what about my mask ventilation, which should give me intubation in my first attempt. So head up position in pregnant women is advocated because it increases the FRC. It also decreases laryngoscope impingement caused by large breasts, and it may also reduce gastroesophageal reflux. But in patients who are obese, you may like to do a ramping up, which basically means that you have to bring the oropharyngeal axis in line by putting some pillows and ramping up. So when you align this axis, you find that you have less difficulty in doing your laryngoscopy. So there are some commercially available pillows too, which are like Oxford Hell elevated laryngoscopy pillow, or the Troop elevation pillow, and or the ramp inflatable. But if you don't have any of these, you can just have a pile of sheets which is neatly packed, one below the shoulder and one below the head. Please do not select any pillow which is lying in the theater. There have been case reports where they have found that the pillows have been the killers. So be sure that you have the proper ramping and the proper equipment to ramp. So talking about pre-oxygenation. So pre-oxygenation, basically, it prolongs the time to desaturation in apnea. And what you should target is, if your machine shows that end tidal oxygen of 0.9, that's the gold standard. You can achieve this by asking the woman to take 8 deep breaths over a minute if it's an emergency section. And that will give you an end tidal of 0.9%, hopefully. But having said that, it's very difficult to achieve that in a pregnant woman. This is one study which was done in a center in UK. In 2020, it was published in 2020. They took 17 maternity hospitals and 895 women, and they found that there was failure of pre-oxygenation in 50% women. They could not achieve the end tidal oxygen of 90%. Most of the women, that is 9.4, had a saturation of less than 90% on induction, and 20% had saturation less than 95% during induction. 19% suffered hypoxemia. So all these patients who suffered hypoxemia, they constitute like they are the ones who had difficult intubation and failed intubation. So we have to be very upfront with the fact that pre-oxygenation, although desired, may not be achieved. So how we can help ourselves? We can help ourselves by doing apneic oxygenation. So one simple way is that you connect the nasal cannula to the patient when you are mass oxygenating, and you can set it at 10 to 15 liters per minute during laryngoscopy. So you continuously oxygenate while you are performing your laryngoscopy. The other one, which we all are familiar with these days, is the high flow nasal oxygen device. There have been mixed opinion about the use of high flow nasal oxygen device in pregnancy, and mainly that is because there is the fat distribution is such that HFNO did not improve the end tidal oxygenation in some studies. So therefore, people thought that this is actually not beneficial. Nasal cannula is good enough. But I came across one study in a European journal in which they have tested the efficacy of high flow nasal oxygenation for maternal oxygenation during rapid sequence. They took 34 parturients, 17 were randomized for HFNO at 50 liters, and 17 were given standard face mask. BMI was more than 35, and rapid sequence induction was followed. The primary outcome was to see oxygenation post-intubation. And they saw that HFNO, the women who were exposed to HFNO had a higher PaO2 and higher ETO2 than the ones who had standard face mask. This is one study which has come up lately. So if at all you have a difficult case in hand and you have the availability of HFNO, I think you can try it out at 50 liters per minute. You can go higher because we have seen that some patients have been benefited with the use of HFNO. So talking about rapid sequence induction, when you do difficult airway, you must always be aware of the fact that there is the incidence of accidental awareness under general anesthesia for cesarean section, which is very, very high. And the reasons are very clear. We use lower doses of thiopentone, we omit opioids, and then we use universally neuromuscular blocking drugs. So this has been shown in the NAP5 project. And nowadays it is recommended to use propofol, because propofol decreases accidental awareness, and it also decreases drug errors, which happens with thiopental. Also remember to keep additional syringe ready with you, because we are not using opioids. So it's always good idea to give additional bolus of propofol during induction. For mask ventilation during RSI, there is no evidence to support that you should not be bagging these women. What you should be doing is, you should be using less pressures. Like if you use less pressure, say about 20 centimeters of water, it has been seen that it doesn't contribute to regurgitation or aspiration. On the other hand side, if you do not do face mask ventilation properly, you do not gently mask ventilate, and you happen to land up in a difficult mask ventilation or a failed intubation, and then you attempt mask ventilation, you may generate very high pressures, more than 50 centimeters of water, and that may lead to aspiration. So it's always a good idea to gently mask ventilate these women during rapid sequence induction. For cricoid pressure, the guidelines have suggested that a cricoid pressure should be of 10 newtons when the patient is awake, and it can be gradually increased to 30 newtons. We all are aware that cricoid pressure can distort the anatomy. If so, cricoid pressure should be reduced or removed so that you can intubate. Definitely when you're inserting supraglottic devices, you need to release your cricoid pressure. Coming to the use of video laryngoscope in obstetric airway.
Kajal, a gentle reminder.
Okay, ma'am, just few slides. So video laryngoscopes give better CL grades. They've got higher success rates, and they are recommended as the rescue devices for failed intubations. Apart from that, they are good teaching tools, and that's how. So this is, if you are not able to insert your video laryngoscope, there are some short handle laryngoscopes also available, but do remember to use them as the first line of management. However, if you fail in all attempts, then please follow the guidelines, and guidelines suggest the use of supraglottic airway devices. Call for help and follow your algorithms properly. Choose second generation LMA, because they have a gastric, they have a port to deflate the stomach. A maximum of 2 insertion attempts should be taken. So this is one article from BJA where it says that should be used for all, for none, or for some. I would say you should select for some, not for all, because we still wait some data, and definitely not for none. So this is another study which says that supraglottic airway devices should be used as rescue, particularly if you have a fasted, healthy, and a low BMI patient. Extubation should similarly be planned, and the staff and equipment should be available. People should not just leave the theater when you are extubating the patient, which normally happens. The scrub nurse, everybody scrubbing the floor and collecting their things. So please, a difficult intubation also happens to be difficult extubation. But if you cannot intubate and cannot oxygenate, do consider front of neck access, and as now suggested, mark your cricothyroid membrane using ultrasonography. Team debriefing is very, very important, which is lacking with most of our centers. It should identify good aspects of performance and improvement, and then the human factors and non-technical skills we should know, as they contribute to a lot of adverse events. Teaching and training, we should always update our knowledge by attending workshops, hands-on workshops. So put together, what are the obstetric airway pearls? We should respect a maternal airway. Do not induce if you think you cannot get the airway. Control airway prior to hemorrhage. If the patient is going to actively bleed, please control the airway. Have backup devices and suction ready. Keep your patient fasted and give acid prophylaxis. Give good position. Sniffing and head up is desirable. Pre-oxygenate well. Call early for help. Follow algorithms. Avoid manipulating nasopharynx. Consider smaller tubes. Use LMA as rescue. So I hope you people make some checklists. And if you are far from these, then I would suggest that everybody must make checklists according to their own center. Thank you very much. I'm sorry for shooting a little bit up the time.
Thank you so much, Kajal. And, yes, we have our next speaker now. Who will be talking on the changing trends in cesarean section and anesthesiologist perspective. Dr. Ketan Parikh is a consultant anesthesiologist at Breach Candy Hospital, and he's a founder president of the Association of Obstetric Anesthesia in Mumbai. And he's a joint secretary of our National Association. And he has done his fellowship, FRCA, from the famous St. Thomas Hospital, London, and FFAR CSI from the Royal College, Dublin, Ireland. And he's a great academician, keeps himself updated with the latest developments in obstetric anesthesia. Over to you, Ketan.
Good evening. At the outset, I would like to thank Madam Gupta for giving this opportunity to be part of this wonderful ICA webinar. Cesarean section is the commonest obstetric surgery, and any change in trends will definitely affect our practice. I have picked up a few areas where it is going to be of any significance to us. The ultimate goal being safety of mother and baby with improved maternal satisfaction. The rate of cesarean sections are rising, and it's a worldwide phenomenon. The WHO recommended rate of 10 to 15% is nowhere near what the recent overall statistics from the world says, which has gone from 12% to 21%. And in India, the last National Family Health Survey of 2015-16 showed a marked increase up to 17.2%. Here is an excellent study on Indian data for cesarean section as per the National Family Health Survey 2015-16. The rise has been consistent at 8% per year from 2005 to 2015. The 17.2% average is actually an average of across the states, ranging from 5.8% in Nagaland to 58% in Telangana. There is so much interstate variation as well. 7 states have more than 30% cesarean section rate, whereas 9 states have less than 10%. In the public between public sector and private sector, within the state itself, there is a huge gap with higher cesarean section rate in private sector ranging from 40 to 70%. There is no acknowledgement of the fact that the lower rate in public sector or in certain states could be because of or it could be a reflection of paucity or the capacity of the facilities, both infrastructural wise and human resource wise, to perform cesarean section and give the mother what they really need. It may be, as I said, a case of too much too soon in a rich affluent state or in a private sector, as opposed to too little too late in a small economically backward states or in a poor public sector. This difference or this differentiation across the various class is coming in the way of actually comparing the cesarean section rate, and this WHO suggested to use Robson classification, where there are different classification, 10 groups are kind of divided. These pregnant patients are divided into 10 groups, and that's what is called TGCS as well, where they can adopt this classification, which can facilitate comparison and analysis of cesarean section rates within and between different facilities across the region and countries. Among the various reasons for indications for cesarean delivery, one of the concern is a rising maternal request for cesarean delivery. On-demand cesarean sections are on rise, and the reason for doing this ranges from convenience to fear of pain, poor labor experience with the previous deliveries, concern about fetal harm and labor and vaginal birth, concern about trauma, concern about needs for the risk of emergency cesarean section and operative delivery, losing control, and in our setup also muhurat or an auspicious time can be playing part. The cesarean section rate assessed in one of the study ranges from about 40 to 60% of cesarean section done in certain states or in certain private setup are on maternal request, and that is something definitely worth knowing about and worrying about in order to know what we can do to prevent or minimize this kind of request. This fact is even acknowledged across the world, and in 2019 January, ACOG came out with a recommendation based on the cesarean delivery, increased cesarean delivery on maternal request, and it said that one must find out the reason behind why the mother is asking for a cesarean section. If the fear of pain is the main concern, then anesthesia, then labor analgesia can be offered, patient can be counseled, and after exploring the reason behind the patient's request for discussing, and after discussing the risk and benefit, if the patient still decides to pursue the cesarean section, then it should be posted after 39 weeks completion. And it is also important that during the cesarean, it should be made to look like a normal cesarean delivery, as opposed to making it look like a big operative complicated situation whereby a music is being played in the OT, the husbands are allowed to stand with the patient, the curtain is dropped when the baby is coming out, immediate baby is put to breast, skin to skin contact is promoted, etc., etc., to make it look like a normal cesarean section. Okay. There are certain recommendations that have come out from WHO in 2021. One of them is about use of prophylactic antibiotics for cesarean section, and they recommend first generation cephalosporin or penicillin given intravenously 30 to 60 minutes before the surgery. There is noted evidence that suggests that third generation cephalosporin may be less effective than penicillin for this indication, and therefore it is recommended to use first generation if not second generation. They just made one caveat that if you are going to use amoxicillin with clavulanate, that is augmentin, for a preterm babies, there is a risk of necrotizing enterocolitis, and hence augmentin should be given only after clot clamping for cesarean sections in preterm infants. Another recommendation that has come is about use of antiseptic agents for skin preparation, and it is strongly recommended to use chlorhexidine for skin preparation. What they recommend is 2% chlorhexidine with 70% alcohol. When it is not available, povidone iodine can be used. However, chlorhexidine is recommended as it is more effective. WHO also recommends use of vaginal preparation with antiseptic agent. Here there is no specific recommendation. Either chlorhexidine or povidone iodine, both can be used. However, chlorhexidine is a slightly preferred option, but majority of the studies are done with use of povidone iodine. A type of antiseptic used for vaginal preparation is something that is very important. However, one must not use alcohol-based solution in order to prevent any mucosal irritations of the vagina. Now, here is an important study and a consensus statement that has come out from the Society of Obstetric Anesthesia and Perinatology regarding neuraxial procedures in obstetric patients with thrombocytopenia. The best available evidence indicates that the risk of spinal epidural hematoma with platelet count more than 70,000 is likely to be very low in obstetric patients over a range of thrombocytopenia diagnoses. What is different in this statement is this consensus statement focuses on only obstetric patients with moderate to severe thrombocytopenia, whereas existing guidelines cover a range of other related topics and patient population and is primarily related to lumbar punctures and not neuraxial procedure, which is in obstetrics more of an epidural as well as spinal anesthesia. This also helps to make decision of whether to proceed with neuraxial procedure in an obstetric patient in a clinical context. So it's a very important statement that has been published very recently in June 2021. Another consensus statement that has come out is management of pregnant patient receiving thromboprophylaxis or anticoagulants. Venous thrombosis is a recognized and a leading cause of maternal death in US. Thromboprophylaxis has been strongly recommended as a key preventive measures to reduce this venous thromboembolism related maternal deaths. However, extended use of thromboprophylaxis in obstetrics will definitely have an impact on the use and timing of neuraxial analgesia and anesthesia for women undergoing vaginal or cesarean delivery. To date, none of the existing recommendations have weighed the potential risk of neuraxial procedures in presence of thromboprophylaxis with competing risk of general anesthesia with a potentially difficult airway or maternal and or fetal harm from avoidance or delay of neuraxial anesthesia. Furthermore, existing guidelines have not integrated the pharmacokinetics and pharmacodynamics of anticoagulants in obstetric population. Hence, the goal of this statement is to provide a practical guide of how to appropriately identify, prepare and manage pregnant women receiving thromboprophylaxis during anti, intra and postpartum period, especially for our case when we get involved for cesarean sections and we need to use regional anesthesia or neuraxial blocks. There are two types of commonly used thromboprophylaxis, and they have given kind of the flow charts in terms of when to use the neuraxial. Neuraxial block and when is it safe. The usual heparin depends on the dose is divided into three categories: 5,000 twice or thrice a day, between 7,500 to 10,000 twice a day, or more than 10,000 per dose. And depending on that, they've given a window period of 6 hours, 12 hours and 24 hours to wait before proceeding safely with the neuraxial anesthesia. It also has given that when there is not enough window given, then you have to assess the difficult airway and balance the relative risk of GA compared to the spinal epidural hematoma. Similarly, they've also given the chart and recommendation for low molecular weight heparin, either low dose or high dose. The low dose is considered as less than 40 milligram once a day or 30 milligram, that is 0.5 milligram per kilogram subcutaneously twice a day, or the high dose is considered as more than 1 milligram per kilogram twice a day or 1.5 milligram per kilogram once a day subcutaneously. For low dose, you have to wait minimum 12 hours, and for high dose, you have to wait minimum 24 hours before proceeding for neuraxial anesthesia. However, if this window period is not met, then one has to consider not to proceed with neuraxial anesthesia or balance the potential increased risk for spinal epidural hematoma versus risk of general anesthesia. Another issue that we all encounter is supine hypotension during regional anesthesia, especially spinal anesthesia for a cesarean section. And this recent article in IJOA in July 21 have said that accurate prediction of spinal anesthesia induced hypotension could enhance clinical decision making, alter therapeutic management, and lead to appropriate early intervention. This study was performed with the aim of summarizing a possible predictor of spinal anesthesia induced hypotension and their predictive value during cesarean section. It consisted of 38 study counting 3,000 plus patients. All patients received about 500 to a liter of crystalloid, either preload or coload. They were all given 5 to 15 milligram ephedrine or 25 to 100 microgram of phenylephrine as a bolus for management of hypotension. The hypotension in their study varied from 30 to 80%. They had more than 30 predictors in these studies, which they divided into 7 domains, and they were based on demographic characteristic, baseline hemodynamic variable, baseline sympathovagal balance, postural or supine stress testing, peripheral perfusion indices, blood volume and fluid responsive indices, and genetic polymorphism. An accurate evaluation of blood volume and fluid responsiveness assessment may predict possibility of post-spinal hypotension. Also, the supine stress test, also known as postural stress test, will reflect the individual's cardiovascular tolerance during hemodynamic fluctuation and may optimize the predictive value of steady state predictors. So, a simple question asking the patient how comfortable are you lying supine and how long can you lie supine may give you some indication of how the patient is going to behave under your spinal anesthesia when she lies supine for a cesarean section. This is a very interesting study, which also leads us to what kind of vasopressors are ideal to be used for hypotension during cesarean section under spinal anesthesia. The range of vasopressors are commonly used. However, an alpha agonist, that is a phenylephrine alpha 1 agonist, is a preferred vasopressor in preventing the hypotension because of its faster onset, its less incidence of fetal acidosis, it is less likely to cross placenta, and has less kind of chance of maternal nausea and vomiting. Ephedrine may also be beneficial in patients especially with bradycardia, because ephedrine can cause tachycardia, and in patients with pre-eclampsia where the use of phenylephrine may cause hyper response. Recently, norepinephrine, that is with alpha 1 agonist with additional beta action, has been studied and has been compared with phenylephrine with his less cardiac depression and has a promising result. However, it is yet under revaluation and there is no specific recommendation for use of norepinephrine. So at the moment, phenylephrine remains the drug of choice to prevent hypotension during cesarean section under spinal anesthesia. There are studies and recommendation of use of prophylactic ondansetron. 4 milligram ondansetron given intravenously immediately after spinal anesthesia has shown to reduce the incidence of hypotension and amount of use of vasopressor. So that also can be kept into account when we are giving anesthesia. This is an excellent international consensus statement on management of hypotension with vasopressor and it says that you must aim to maintain systolic blood pressure at around 90% of the accurate baseline obtained before the anesthesia was given. Avoid reduction less than 80% of baseline at any cost. Recommends a variable prophylactic infusion of phenylephrine using a syringe pump 20 to 50 microgram per minute. Should be started immediately after the intrathecal local anesthetic injection and titrated to the blood pressure response. Ephedrine may be used for less than 90% blood pressure drop with low heart rate. A bradycardia with hypotension can be treated with use of glycopyrrolate or atropine. Okay. Now the new things about use of uterotonics is again a new guideline or an international consensus statement that has come out, which says oxytocin is the first line of choice and should be given as a first routine administration. The requirement, very interestingly, the requirement for intrapartum cesarean sections are several times higher than that of elective cesarean section, and hence there is no one dose suits for all. The recommendation from the guideline is that if you are going to use oxytocin, give 1 unit of oxytocin intravenously followed by an infusion for elective section, as opposed to 3 international units over 30 seconds for an emergency or an intrapartum cesarean section. Large doses of oxytocin should be avoided to minimize the antidiuretic effect. Another option is carbetocin, which is actually a longer acting oxytocin working on the same receptors and has same adverse effect profile, but it eliminates the requirement of an infusion after an initial dose. So again, if available, carbetocin is recommended. The second line of agents should not be delayed if there is a slightest doubt of PPH, and they should be considered promptly. If in a resource constrained setting, intravenous or IV access is not available, intramuscular route can be considered to be used. Second line of agents are mainly ergometrin, misoprostol, carboprost, and should be used at the earliest in order to avoid major PPH. I'm not going to dwell into PPH, but this was just something to talk about uterotonics. Following this, I just want to mention one thing. Tranexamic acid has been proven efficacy in women's trial to prevent death and use in postpartum hemorrhage. However, it has become a very good friend of all obstetricians, maybe with a bit of a commercial push. It has found its way in all OTs, and now a lot of people are pushing it and using it for prophylactic use and prevention of PPH. At the moment, the evidence is lacking, and there is no reason to use tranexamic acid as a prophylactic medication. However, the concern about tranexamic acid is in last 10 years, there have been 21 case reports of inadvertent intrathecal injection of tranexamic acid while giving intrathecal spinal, and that has caused 70% to 80% of mortality. So this is something that I just wanted to point out with this slide, that one has to be very, very careful, and it is very important to avoid the drug error with the use of tranexamic acid. Pain during cesarean section under regional anesthesia is again increasing a medical legal issue, and we need to make sure that we don't let the surgeon start without checking the block and document it properly. The level of the block must be checked bilaterally. There is no consensus as to best practice of how to check the block. However, the modalities to be checked are sensory modalities by use of cold and light touch. Motor modalities can be checked by use of bilateral, by Bromad scale. Bilateral Bromad scale should be less than 3 by 4, or sympathetic bilateral warm and dry fleet. The ideal level to limit the block should no cold or cold sensation from S5 to T4. There should be no touch at all or a very light touch. from S5 to T5, and the cause of concern should be if there is a cold felt at T5 or below, or there is a light touch felt at T8 or below, the bromide score, and if the bromide score is less than 3/4 after 10 minutes, it's a cause of concern. So one must check the level properly before allowing the surgery to start. Also, it is important to have a backup of how you're going to manage if the spinal fails. I'm not going to go into detail because this is going to take a lot of time, but every institute, every practice, you should have your own backup. But the most important thing is that if the patient complains of pain, stop and reassure and reassess the situation before continuing further, and believe them when they say pain. Okay, so it's really now in the era of eras, SOAP has come out with a recommendation for enhanced recovery after cesarean, and basically the purpose of this article is to provide summary and recommendation, and the goal is to focus on optimizing maternal recovery, maternal infant bonding, and perioperative outcome after cesarean section. They have identified and divided into 5 preoperative elements, about 9 intraoperative elements, and 11 postoperative elements in order to improve the outcome. However, from our point of view, how we can contribute is by minimizing the fasting. We suggest preoperative oral carbohydrate loading, use neuroaxial anesthesia, administer antibiotic prophylaxis, initiate multimodal analgesia based on long-acting neuroaxial opioids, administer prophylaxis for intraoperative as well as postoperative nausea, vomiting, maintain normothermia, and optimize IV fluid administration aiming euvolumia, promote skin-to-skin contact, mother and neonate, and breastfeeding. Okay, here is an excellent study called Prospect Study by the European Society of Regional Anesthesia, supported by Obstetric Anesthesia Association of UK, which gives guidelines for postoperative pain relief in elective cesarean section. The aim is to minimize systemic opioid use. They recommend using intrathecal morphine 50 to 100 microgram, use of paracetamol with non-steroidal anti-inflammatory when it is not contraindicated. A single dose of intravenous dexamethasone 8 mg after every delivery is recommended and has been proven to be a good post-op analgesic. Use of local infiltration or abdominal field block, especially in absence of intrathecal morphine, is recommended, and TAP blocks and quadratus lumborum blocks are the ones which have been practiced routinely with the use of ultrasound guidance. However, there is new normal in today's day and age with this pandemic, and there are medical consideration as well as social and psychological consideration when we are doing a case in today's day and age. Every patient is a suspect unless proven otherwise. We should be very careful about our anesthesia technique. Neuroaxial anesthesia is preferred. One must check the platelet count. One must remember that patients with COVID will have excessive hypotension with spinal, and a prophylactic vasopressor infusion may be recommended. The uterotonics should be given carefully as they may cause serious instability. Non-steroidal anti-inflammatory, though were considered dangerous in early days of pandemic, are considered as safe and is okay to be used for analgesia. And along with pregnancy, COVID being hypercoagulable state, one must use low molecular weight heparin for post-op prevention of thrombosis. Also, one must remember that these patients, if they are positive, they may be already on low molecular weight heparin preoperatively, and that needs to be timed with your cesarean section. There are social and psychological consideration both for the parturient as well as the medical team, who all go through anxiety, depression, and sleep disorders, and this needs to be taken into consideration. Small gesture that we have is that in this situation, while the husband cannot be there, And in order to maintain the ERAS and to maintain the good experience, what we have is the husband's mobile in the OT with the stand, and the patient can be communicating, husband can be watching the baby coming out, and this gives them a little virtual presence and makes a slight better experience. So this is something that I normally do in this last 1.5 year. We've been doing it in our place. However, one most important thing is that personal safety is very important. I am not going to go into detail, but don't let your guards down, and you maintain that you adequate personal protective equipments are donned before you encroach upon this, because we have had enough surprises where pre-operative negative patient turns positive post-op, and there are certain case reports that suggest that we have had where suddenly patient develops symptoms just post-delivery, and then you turns out to be positive after 24 hours. So you don't know which patient is going to throw surprise, and it is very, very important that we maintain our safety at the high. So to conclude, I just want to say on-demand cesarean is on rise. 70,000 platelet is a safe in obstetric practice to give neuroaxial block. ERAs are dedicated to improve maternal experience with safety. Phenylephrine is the vasopressor of choice at the moment. Role of tranexamic acid as prophylaxis in PPH is not evidence-based and is the highest concern for drug error. Ondansetron as a prevention of hypotension is recommended. Dexamethasone and field block for post-op analgesia is something that one needs to consider, and COVID appropriate behavior is the new normal. I know I have encroached upon 4 or 5 minutes extra, but the topic was really wide. I'm sorry, and thank you very much for listening.
Thank you so much, Ketan. And now I would request all the panelists to come in. Dr. Purva, Dr. Sunil Pandya, Dr. Kajal, Dr. Ketan. Have I missed out anyone? And Anju Grewal, if you are there, please do join us.
Ma'am, Sunil is also there.
Yeah, I have asked Sunil to join. Sanish, could you please unmute them?
And they are already promoted as co-hosts.
Purva says she cannot unmute herself. Sanish, please help her out. Yes, can you put your video on, Anju? We cannot see you. Sunil Pandya.
I'm there, madam.
Okay. So Purva, are you there? Shall we start with your questions?
Yeah, Dr. Purva's audio video is enabled now.
Enabled? Yes. You cannot speak for that. Yeah.
No, I can now, ma'am.
It's too long a distance.
Thank you.
Up to Hull University, I think there is a delay in communication. So it is nice that you could join us. So Purva, the first.
Bye. Bye lag rahi hu.
Anju, we can hear you. A 24-year-old full-term G1P1 with a history of pre-eclampsia. She has a platelet count of 60,000. She's stable for the last 2 hours. She's morbidly obese with a BMI of more than 30. Her airway MPG grade is 3. She has CREPS, bilateral lung bases, is posted for cesarean section. And her SpO2 is 93. And she's comfortable sitting up. There is no cough. Now, this resident says that my dilemma is regional or general anesthesia. Her RT-PCR is negative. I do not have a fiber optic endoscope, but have a video laryngoscope. So, ma'am, how should I manage this patient?
I think it's a very interesting problem and something, and it's a dilemma that we have always, isn't it? Being an obstetric anesthetist trained under Ian Russell, can you hear me?
Yes, we can
Yeah.
hear.
Yeah, so being trained by somebody who strongly believes that regional should be the modality that you should go with first. I suppose my initial inclination would be to go for a regional. Having said that, this is a patient, obesity again with BMI of 30 is not something that would put me off because BMI 30 now has become the new normal, just like COVID has become the new normal. And with ultrasound, which we use quite routinely now, BMI 30 is not a problem. I think the bigger problem would be the fact that she's got Krebs and lying her flat might be a problem. Yes, of course, the platelet of 60 means that you do not know what her the function of her platelets are, so therefore spinal is not a great idea. Now, the video laryngoscope, having a video laryngoscope is brilliant. I mean, I think that has saved our lives many, many times. Increasingly, now I find obstetric anesthetists are going more for GA. They're more confident using GA. We have appropriate drugs. We have, you can control the blood pressure more appropriately at the time of induction. And if you have a sensible obstetrician and you have a sensible HDU standby, you can actually do a very safe GA, provided that MDT discussion is in place and you have everybody lined up. So that would be my approach.
Thank you, Purva. There's another question.
Can I just add to that, madam?
Yes, Sunil.
Yeah. Hi, Purva. How are you?
Sunil, we can't see you.
Yeah. So this particular question, yes, we very frequently we see this in our country, but more importantly, what I would like to emphasize to the postgraduate or the consultant who has had this patient is categorize the cesarean section, because with the crepitations, bilateral basal creps and SATs of 93%, I would stabilize the mother. And if the treatable cause of pulmonary edema, which is could be fluid overload, or it could be a coincidental heart disease which has been missed out. So I would like to evaluate the patient if it is not a category 1 section, stabilize her, and then do what Purva has said. Go according to that plan. But yes, categorizing cesarean section, stabilization, improve the saturation if you have a time, and then go for cesarean section.
Thank you, Sunil. Now, the next question for Purva is that this resident doctor from Jaipur says that in pregnancy, the doses of your LMWH, low molecular weight heparin, varies because of decrease in albumin. So there is an increase in the drug in the unbound form. So she says that, how do I confirm that even after 12 hours, is it safe to give regional anesthesia? Are there any investigations which could tell me that the patient would not bleed into the intrathecal or the epidural space? And so what should I do? What investigations would be the best here to find out?
I think the first thing to say is it's a very, very clever question, and you're addressing it to a person who's not that clever. So I will do the best, and I'm sure there'll be more cleverer people on this panel who can answer it. So, but what I would say is the thing with low molecular weight heparin, at the end of the day, I think it's always the benefit risk. Medicine is about benefit risk analysis. You can never ever have a test which will confirm to you, categorically whether the spinal epidural is safe under any circumstance. Ultimately, it depends upon, so if you have a pre-eclamptic patient, you have a patient who would benefit not having a general anesthetic, and if there's time to do a regional anesthetic is always safer. For any patient, for any procedure, if it is a pregnant patient, my first question to myself is, why should I not do a spinal? Why should I not do an epidural? You have to give me too many reasons, only then I'm likely to go for a GA. And low molecular weight heparin is not one of them. And if the spinal is safer, then that is what my suggestion would be. I wouldn't worry too much about going for complicated, analysis. You can have a TEG, perhaps, bedside TEG monitoring. And a lot of places now have it because I think it's useful to have a better idea of platelet function analysis. If you don't have it, I wouldn't worry too much about it, but go with other factors and make your decision on that basis.
Sunil, do you want to put in something?
Yeah, that was a clever answer, Purva. But yes, see, there are no rocket tests for LMWH activity. Earlier, if you read most of the literature, early 2000 and mid 2000, they used to measure plasma levels of LMWH, and they used to do factor 10 inhibition assay, which are practically impossible and theoretical in the current clinical scenarios. So we just go by most of the studies and the standard literature. Prophylactic LMWH wait for 12 hours, and if it's therapeutic, wait for 24 hours. And that, by and large, that is considered to be safe. Yes, if it's unfractionated heparin, if the dosage is more than 15,000 to 20,000 units per day, you can always get an APTT done, which can guide you. But for LMWH, no bedside tests. You just have to go by the time.
Another question is about post-operative pain relief when the patient is on anticoagulants, low dose UFH or LMWH, and the patient has an epidural catheter in place. So normally what we give in India is acetaminophen and NSAIDs, a combination of them. And mostly the patients are already on aspirin. So what should I continue and what should I withhold in this scenario? Should I continue, Purva? Should I withhold any of these drugs or should I continue them?
Yeah, so it says my internet connection is not stable, but so this is somebody who's on low molecular weight heparin, and
they are on low doses. And she has an epidural catheter in place.
Yeah, so this is for post-operative pain relief after cesarean section.
Yes, so she's worried whether I can continue my NSAIDs and acetaminophen in this situation.
Yeah. Yeah, I mean, I think that isn't an issue at all because we give regular, so we are one organization, I think, where we actually give high dose diclofenac, which is 100 milligrams BD, which is a massive dose for 3 days. We are licensed to use it in our organization. But I think the real point here is it all depends on your pre-eclampsia. I mean, this is a background, isn't it? Ultimately, post-operative period is, you can still have a worsening of the pre-eclamptic condition. And at any point, it can go into HELP and, all those sort of, that backdrop is still there, that worry is still there. So if you give a combination of drugs, which then have an impact on platelet numbers or platelet function or whatever. So I think ultimately it depends again on considering what the requirement for the pain relief is. So normally we do not continue with an epidural. We remove the epidural catheter. We shift the patient onto oral medication, and it is done with that. So I think if you're having an epidural catheter in place as well, actually pain relief after cesarean section is actually is not such a big deal, especially if you have spinal diamorphy. We don't find it such a big problem post-operatively. So I wouldn't worry too much about it, but my worry would be, are you monitoring this patient for any late complications, such as eclampsia and everything else? And that might be a bigger issue for you rather than worrying about pain relief, I would think, because if you have that epidural in place, when are you going to remove it? I think that is a bigger problem for you, because I have seen an epidural being removed inappropriately and the patient getting an epidural hematoma and getting paralyzed. So that for me is a bigger issue. I don't know if I've answered your question though.
I think that's it. Now we come to the chat box. If you can see some questions there. How does
so there's a question on
Yeah.
Is that a, I think there was a question on FFP, I think.
NPG may cause PPH. What is your opinion? Nitroglycerin. You used it with esmolol and remifentanil to prevent that sympathetic response during intubation. So he wants to know whether
yes, that's right.
Can cause PPH.
Esmolol can create. Sorry, again I missed that.
Nitroglycerin, can it cause postpartum hemorrhage? Because you are
right.
using in a pre-eclamptic.
Yeah. It's a very small dose that you're going to use. I mean, I can't see it contributing that significantly to PPH. I think your bigger problem is going to be the direct impact of preeclampsia, prolonged labor, uterine atony, that sort of an issue is more likely to produce your PPH. But what we're going to use for intubation is not a big, it's not going to have a big impact on the PPH, provided you're not using it as an infusion and just using it as a one-off.
And then, is there any role of therapeutic epidural increase uterine blood flow in pre-eclamptic patients with intrauterine growth restriction? Purva.
Yes. So I missed the first part of your.
Any role
so there was intrauterine
growth restriction, and he wants to use a therapeutic epidural to increase the uterine blood flow. So is there a role of therapeutic epidural?
It's a very, I think all this is a topic for a future study, if you can get consent.
Actually, ma'am, there was one article long time back. It came in one of the feto-maternal journals.
Japanese journal.
Yeah, they had mentioned, but there are so many pitfalls with it. Like the person has to be taped to an epidural, and every day they would do a Doppler and see whether the placental blood flow is being improved. That's a research topic totally. Like,
how do you get consent? I mean, I find it interesting.
I don't know
that
was a very small study. Very few patients were done, but they did see that the baby remote from term, like preeclampsia remote from term, in which like you feel that the baby will be benefited by just about some blood flow to the baby and growth. They had studied the feasibility, but I don't think it's practical. It may be seen case to case.
Thank you. I've learned something today.
What is the lowest platelet count that one can safely perform a neuraxial block?
I think that everybody in the panel can answer that, isn't it? I mean, we all have our favorite numbers.
Yeah.
For me,
I've done. Ketan has answered that in his talk. I think that is what is the risk versus benefit analysis. Risk versus benefit analysis. If you ask absolute number 70,000 and above, anything below that is a gray zone. And whenever you're doing platelets in a patient with, neuraxial in a patient with low platelets, the risk versus benefit has to be always prioritized and do what is best for the patient. But if you ask the absolute number, 70,000 is the cutoff. But if you have a stable trend.
Have you gone? Sunil, how much lowest have you gone? What is the lowest number you have?
The lowest anecdotally I've gone is 9,000 epidural.
She must have been a very high risk patient then.
That was anecdotally. We got to know later on.
Later on.
Okay, you got to know.
But it was uneventful.
Yeah, but the incidence is so low, 1 in 200,000, 1 in 250,000 about the spinal.
But yes, trending is important. What you need to do is trending. And the cause of low platelets.
Yeah, it's interesting.
Yes, Purva.
It's interesting because we do lumbar punctures. We do lumbar punctures for so many patients. This is non-obstetric, where yes, and therefore, we don't have any problems there. So, so the argument from the hematologist is always because they don't give you the platelets that easily. The argument would be if it's just a one-off, you can do it. But the worry is what happens afterwards, isn't it? It's not just your spinal, it's for the surgeon, the problem. So, yeah.
But recently, SOAP has been advocating giving platelet transfusions if the patient is bleeding. to bring the platelet count above 50,000. Their latest in
Yes.
2019 there.
Yeah. I think that's a sensible thing as well, isn't it? Provides you cover as well to do your spinal and get out before it, and for the surgeon as well, and provide the best possible environment to reduce bleeding. So yeah.
Now there's a question, how does ondansetron prevent hypotension? Anyone?
I think that's Ketan Parikh who should
Yeah,
answer.
yeah. Ketan's question.
Ketan.
I can answer that. What is the question? Sorry, I missed the question.
Ondansetron is a serotonin 5-HT3 receptor antagonist, which you say is the prevents hypotension, postspinal hypotension. How does it do that?
Madam, you are the one who's done that study, right? You just published that.
I'm
Why
the
don't you answer
I'm supposed to be asking questions, you know.
But if one question you can also answer.
So yeah, basically they say that the systemic vascular resistance, one of the reasons is that sympathetic block. So there is overactivity of the parasympathetic, and so that stimulates the Basal-Jarrett's reflex, and so it causes hypotension as well as bradycardia. So serotonin is also one of the reasons why it stimulates the BJR reflex, and ondansetron is supposed to, being a serotonin antagonist, it helps it, it causes, prevents hypotension in these cases. Okay, then do you need to do platelet count of PTTT with platelet of 70,000 for neuraxial procedures? Does this apply to both spinal and epidural?
Yeah, generally as a protocol, when the counts are less than 1 lakh, we have made it mandatory to get a bedside PT done in our hospital. But having said that, if the category 1 section is there, then you don't have to wait for the reports because it takes almost about 45 minutes to 1 hour. So if you have time, just definitely wait for those reports to come. Because many a times the low platelets can be associated with HELLP syndrome. And we need to rule out that. And suppose if it is a INR is elevated, fibrinogen is low, then definitely it's no, even if it's 70,000.
Factor 10A for LMWH.
Yeah, factor 10 inhibition assay is one of the tests to know the activity of LMWH, to know the anticoagulant activity. But again, that as I said, it takes almost about 24 to 48 hours to get the report. Theoretically, yes, but practically it is not possible.
Yeah, in the absence of that availability of factor 10 assay, one can do APTT, and that also can sometimes serve the purpose.
But LMWH, again, APTT is of no use.
No, I'm talking about the heparin, just the regular heparin.
Yes, unfractured heparin, yes.
Yeah.
With UFH.
Yeah.
Is there any role for FFP to correct for patients on LMWH and you can't wait like you would do for UFH?
No, absolutely no, absolute no.
Absolutely. There are a lot of excellent topics and presentations. Great session. What happens to intrathecal dose of bupivacaine in severely growth restricted baby posted for cesarean section? Oh my God.
And
nothing happens. As long as there is no hypotension, everything is fine.
Nothing happens.
Is the reason for that question is a person, I'm trying to find a link why they've asked that. Is it because they think the block might go higher or something like that? Because it's a small baby. It doesn't have any difference, I know, but I'm just trying to understand what was the...
Yeah, many a times, suppose if it's the epidural bupivacaine or lignocaine, then yes, there is iron trapping because of acidotic pH. Then you can have relatively higher concentration of local anesthetic in the fetal circulation. But for spinal, I don't think that 10 milligrams is going to cause any issue unless there is hypotension.
I think with this, we come to the end of our discussion. I don't find any more questions in the chat box. Thank you so much. And I would request Dr. Jayashree Sood.
Hello, everybody. Yeah. Hello, everybody. Saying good evening at this moment will, of course, not be appropriate, but hello, everyone. And it's my proud privilege to propose the vote of thanks today on behalf of the ICA. First of all, thanks, Sunanda. Well, you are such an important member of the ICA. So really, you are the host also. And really, congratulations for the excellent title that you chose for the webinar, Changing Scenarios, and all the stalwarts that you selected to talk in this webinar one is absolutely, awesome. And the compliments that we have received in the chat box is definitely testimony to that. And the number of queries that were asked just shows the standard of the webinar. So thanks a lot, Sunanda. And individually, I would like to thank Dr. Kodali, Dr. Purva, Kajal, and Dr. Ketan for taking out their valuable time for this webinar. Of course, Kajal is also part of the ICA, and the excellent, lively panel discussion we had in the end with Sunil contributing his experience. So once again, thank you very much. Thanks, everyone. And Sunanda, thanks a lot and good night.
And thank you to the audience.
Yes, of course. Absolutely. The webinar is always.
Excellent job. Sanish has been a great help.
Sanish is always there, and he's been, just taking the ICA to greater heights. Thanks a lot. Good night. Thanks a lot. Bye-bye.
Good night. Bye.
Good night. Thank you.